This session is all about lesion, optical diagnosis and lesion detection in the upper GI tract, something which I think is not easy to do, something which I didn't find easy when I started training, something I think a lot of people out there are finding difficult because they're not 100% sure what these things look like. And so we hope to change that in the next hour and a half, 2 hours or so. So the objectives are select the right endoscope and accessories based on the indication. And that's a critical thing because endoscopes are now very advanced, very different. And if you choose the wrong endoscope to assess a lesion in the upper GI tract without magnification, without great bending, then this can be a major issue for you. Execute systematic inspection protocols for Barrett's esophagus, squamous lesions, and gastrointestinal metaplasia. And these conditions are the conditions we're trying to focus on in this day of this symposium. These are conditions which increase the pretest probability of you having cancer in the upper GI tract, and therefore the ones where we should apply focused algorithms, bring expertise, and slow down. Apply standardized classifications to stratify risk. Use chromoendoscopy. Hopefully we will demonstrate to enhance dysplasia detection, and we hope to demonstrate what's possible doing that, and distinguish between benign and malignant lesions through really simplification and understanding that really it's about the regularity of the mucosal vascular pattern. The quiz question, which of the following best reflects the principle of right scope, right risk in lesion assessment? I will leave you to read these, and I will leave you to vote on which one you think is the correct answer. And if you're first, 10 Geeks coins. What's a Geeks coin? Tell you next time. Okay, so let's move on to the first presentation. I think it gives me great pleasure to welcome Ruth to the symposium, and thank you very much for being here and giving her expertise and giving this lecture, first of all, on seeing what matters in Barrett's esophagus.
Thank you, David. So again, it's a pleasure to be here today at this very exciting symposium. And so my talk is about Barrett's esophagus, which I always like talking about. And now we're going to focus on seeing what matters. My disclosures. And I just wanted to start by pointing out some parts of the ESG guideline on Barrett's esophagus. And I'll start with a no-brainer. Like the discussion we had this morning, do you have to clean during your upper GI endoscopy, and will that improve lesion detection? We said it's a no-brainer. We don't need much research to say that cleaning helps. And the same, I think, holds for this recommendation, because in the guideline, we advise a minimum of 1 minute inspection time per centimeter of Barrett's esophagus during surveillance endoscopy. There has been a study looking into this, and there has been some critiques on this study, that there were some drawbacks, etc. But I think the bottom line is that it's also a no-brainer that if you inspect longer, that you will detect more neoplasia. So make sure that you have enough time if you're going to do a Barrett surveillance endoscopy. It's not only that you look longer, but you also need the time for cleaning, for pull-throughs through the Barrett segment, for virtual chromoendoscopy, and for accurate photo documentation. So you just need the time and just take it as well. Don't rush into it. So usually after the cleaning, and this is an example of a very clean esophagus, I first make a pullback in white light just to assess the whole Barrett segment, starting distally at the hernia or the cardia, and just slowly pulling back. I usually do one pullback just on the go, and the other one where I pause and freeze the video every centimeter, make a picture, and take that time to inspect. And after I've done the white light pullback, I usually do the virtual chromo pullback. And you might have already seen a lesion with white light endoscopy. And this is blue light imaging. So it's the virtual chroma endoscopy from Fujinon. And you can clearly see that the lesion that we saw in white light also nicely stands out if you're using blue light. And you can also assess the rest of the Barrett segment. And a prerequisite for this is that you have cleaned and that you take the time to do a thorough pullback. And once you've done that, you get a better idea of what you're looking at. What we also advise in the ESG guideline is to photo document. May take one picture per every centimeter of the Barrett's, and always inspect the G junction in the retroflex position. I'm sure Raf will illustrate that during the live procedure, but I think this is often forgotten. It's a very easy maneuver. Make sure you have an endoscope that angulates well. Turn on your knobs. Also use your small wheel. Slowly pull back your endoscope. And this really allows you to clean and inspect this area up close. And we know that this is an area where neoplastic lesions are easily overlooked. And it's really important because if it really looks normal and to great, you can really have a big lesion in the retroflex position that can very easily be missed, like in this example. So always do this maneuver and make a picture of it. Also, we advise using the PROC classification to classify the Barrett length and the Paris classification to classify any visible lesions that you might find. And I said before, I'm not a big fan of all very complicated classifications, but I think the PROC and the Paris are very easy. So for the PROC classification, you measure where the G junction is, how long the circumferential extent of your Barrett's is, and how long the maximum extent of the Barrett's is. So it's a very easy classification, and this sort of forces you to look at the Barrett's in a very structured way every time you do these endoscopies. And the PROC classification helps you then to calculate how many biopsies you need to take. In this example, this is a C1 M4 Barrett segment. So this means that if we use the Seattle biopsy protocol, you need to biopsy from 4 different quadrants at 2 levels. And